Okay, so we are now connected. Hello, everyone, and welcome to today's webinar, Clinical Approach of Women with Androgen Excess, the case of PCOS. It will be presented by Professor Dimitrios Goulis. He is currently head of the unit of reproductive endocrinology at the Aristotle University of Thessaloniki. Also, he's scientific director of the Training Center in Andrology of the European Academy of Andrology, Secretary General of the European Academy of Andrology, and Secretary General of the European Menopause and Andropause Society. He's associate professor in reproductive endocrinology also at the same Aristotle University. So my name is Daniel Correa, and I will be your moderator for today's event. Before we get started, I would like to go over a few housekeeping items so you know how to participate. So you've entered this webinar as only listen mode. This means that your microphone is muted. The reason we do this is to avoid picking up any noises from your end, so we have a better sound. We do welcome and encourage to submit your text questions on the question panel that you can see in your webinar control panel. So please enter your questions at any time, and I will be saving them for after the Q&A. At the end of the presentation, I will be reading the questions to Professor Goulis. Okay, so let me tell you that we are recording today's webinar. This means that it will be accessible for you at any time you want in the EMAS website. Also, at the end of the webinar, you will receive a brief survey on the control panel, and we would appreciate very much your responses. All right, so thank you for joining us today. Now I would like to introduce our presenter, Professor Goulis. Welcome, Dimitrios. You have now the floor.
Well, thank you very much, Daniel, for all the technical support, and I'd like to thank all of you for your kind attendance today. Well, in the next 30-35 minutes, we are going to discuss a hot topic in reproductive endocrinology, which is polycystic ovary syndrome. So after mentioning my conflict of interest, okay, let's put some aims for today's presentation. The first is to review the definition, pathogenesis, diagnostic and therapeutic approach of the polycystic ovary syndrome, and I will try my best to incorporate the knowledge acquired from the basic sciences into the clinical practice. I'll try to be as practical as possible. So every time that you are going to see this green triangle on the left, on the left top of your screen, that means that we are going to discuss an actual case. And having this case as a start, we are going to discuss different aspects of the syndrome, of the polycystic ovary syndrome. So in our case, we have a young woman, 22 years old, that was referred to your department as in a routine gynecological ultrasound, polycystic ovaries were observed. The first thing that crosses my mind is that having polycystic ovary, that is, the morphological appearance is a different thing, and a different thing to have polycystic ovary syndrome, to have the full syndrome of this. So up to now, our woman, our case, has only polycystic ovaries. And this is the appearance of the normal ovary, its anatomical appearance. And here on the right is the ultrasound of a normal ovary. You can see some mature follicles there. On the other hand, this is the typical approach, the typical appearance of a woman with PCOS. So multiple follicles that they are arranged at the perimetry, at the peripheral of the ovary. The same is true in the ultrasound appearance of this. Many small follicles, something like from 2 to 10 millimeters, and more than 10 in number that constitutes the definition of polycystic ovary, not the polycystic ovary syndrome. Now, how do we think, once again, on clinical grounds about the syndrome? What's happening in the genital tract of women? This is kind of normality, that is a normal ovary in a normal woman that starts to mature one of the follicles, the follicle that is going to be the cardinal one for the specific cycle. Of course, this growing follicle is producing estradiol in increasing amount. At a certain time of point, usually 14 days later, we are going to have ovulation, the phenomenon that we call ovulation. After this, the follicle is going to be replaced by the corpus luteum, which is going to produce progesterone for the second phase of the menstrual cycle. Going from the ovary to the uterus plant, you can see that at the beginning of the cycle we have a very thin endometrium, and this is because we are just after the menstrual period. So all the functional layers of the endometrium have been actually they've been gone away in the form of menses. And what is happening is that under the drive of the increasing levels of the estradiol, this layer is going to be made once again. So at the end of the period, we have normally a thick endometrium. So this is what's happening in a normal woman, normal menstrual cycle at an ovarian, at a uterine level. Now, concerning PCOS, things are like this. At the beginning, we have a lot of follicles, growing follicles, that in a way, one arrests the progression of the other. So we have no cardinal follicle. Of course, these follicles produce estradiol, so estradiol levels are normal in women with PCOS. But on the other hand, none of this will be transformed into the cardinal, into the main follicle of the specific month. So they are going to have a stable situation. The ovary remains at the same morphological appearance, continues to produce by these growing follicles estradiol, but we have no ovulation, we have no corpus luteum, we have no production of progesterone. That is why, once again, on a uterine level, we have a thick endometrium, and this is because of the continuous production of estradiol, and this remains the same all over the cycle. So once again, this is what we are going to see at an ovarian and at a uterine level in both a normal lady and a lady with PCOS. Now, this brings us in front of us the first cardinal clinical sign of PCOS, and this is menstrual disturbances. So we may have the best we can do, that is 12 menstrual periods per year, one per month, up to the other end, something like zero, no periods at all. That is the definition of amenorrhea. Our woman could be everywhere there in this spectrum from 0 to 12. So a woman may have with PCOS, with polycystic ovary syndrome, she may have 10, she may have 6, she may have 3, as in this case, or she may have no periods at all, that is amenorrhea. The second cardinal feature of PCOS is androgen excess, excessive production of androgen, usually by the ovary. Once again, this is going to have clinical features, and the clinical features of androgen excess are different. It may be hair loss, it may be hirsutism, it may be acne, it may be anything like this, it may be seborrhea. So once again, we may have something for the excellent skin, no problem at all, up to very severe dermatological skin problems. once again, in this example, our lady could be here or here or here. And it's something that we see it very commonly in clinical practice, that ladies with PCOS may have mainly menstrual disturbances and very few symptoms of androgen excess, as this is the case in this example, or we may have completely the opposite, to have almost normal period, so no menstrual disturbances, or on the other hand, to have a great degree of androgen excess. So basic to these clinical characteristics, in 2003, there was a consortium, a consensus between the main European society dealing with these issues, and this is the ESRE, and the American corresponding American Society, ASRM, American Society of Reproductive Medicine. So they have a consensus about the diagnostic criteria of polycystic ovaries. These are known, because of the city that this consensus took place, as the famous Rotterdam criteria for PCOS. So according to this, in order to define a woman as having PCOS, 2 out of 3 criteria must exist. The first is oligomenorrhea or amenorrhea, and of course this reflects the pathophysiological background is oligo-ovulation or anovulation, according to what we have already discussed. The second is a degree of androgen excess, and the third is the PCO morphology, the ultrasound appearance of the ovary. So according to the Rotterdam criteria, 2 out of 3, any 2 out of 3, so any combination of 2 has to be exist in order to set the diagnosis of PCOS. Of course, another very important fourth criterion is to exclude other causes, and these are diseases that can result in oligomenorrhea, such as congenital adrenal hyperplasia and tumors that secrete androgen. Diseases like this, of course, they may result in oligomenorrhea, androgen excess, even PCO morphology, but they are not PCOS. They're something else. They're congenital adrenal hyperplasia or tumors. So we always have to exclude this. I have to say at this point that the Rotterdam criteria is not the only definition of PCOS. Before Rotterdam in 2003, we had the definition set by the National Institute of Medicine in the States, of course, saying that we must have oligo-ovulation as a cardinal feature plus the androgen excess. So we have to, we must have a combination. Both of these criteria have to be present. They pay no attention at all to ultrasound morphology. As we discussed, Rotterdam criteria inserted the third criterion, the US morphology, and we have another newer definition by the Androgen Excess Society in 2006, saying that there is no PCOS without androgen excess. So this has to be always present. Androgen excess is number one, and then we must have something else, and this has to be either, second criterion, this has to be either oligo-ovulation or US morphology. We're going to discuss today mainly on the Rotterdam criteria, but it's always good to know that there are other definitions from other societies. Now, if these are the list of criteria in order to have a diagnosis of PCOS, what's the maximum of criteria? What do I may expect in a woman with PCOS? I always have in my mind 4 words, and this is problems for the genital systems, or the genital system, androgen excess issues, of course, issues that has to do with the hypothalamus and the pituitary gland, and components of the metabolic syndrome. So this is the full clinical picture, and I'm going to discuss them one by one. From the genital system, I expect, of course, a degree, it's in the definition, of oligo-ovulation. We may go up to anovulation. As far as we have no ovulation, most probably no periods will come, so the clinical phenotype of this will be oligomenorrhea or amenorrhea. And sometimes, it's not very common, but it happens to have the opposite, that is dysfunctional uteri bleeding as the main symptom. And of course, as far as we have continuous drive, continuous stimulation by estrogen without the intermission of progesterone, we may have endometrial hyperplasia and eventually even endometrial cancer. Of course, infertility is another problem because we have the pathophysiological background, that is oligo-ovulation, and if the woman manages to get pregnant, we may have increased rate of spontaneous miscarriages, most probably because of the increased androgen. So this is the full picture concerning the genital system. Concerning androgen, as we have discussed, we may have a degree of hirsutism, we may have acne either on the face or on the back, we may have seborrhea, we may have hair loss, and of course, at a laboratory level, if we are going to measure androgens, either testosterone, the most potent, or delta-4 androstenedione or DEAS, it's very probable that we are going to find them increased, so a degree of hyperandrogenemia. The third component of the picture is, as I said, issues from hypothalamus and pituitary, so we may have increased LH from the pituitary, so that results in an increased LH to FSH ratio, and sometimes we see slightly increased prolactin, most probably because of the increased level of estrogens. So a mild degree of hyperprolactinemia is something that we see quite often in the clinical practice of PCOS. The fourth and last component of the clinical picture is the metabolic syndrome. So we may have obesity, insulin resistance is the background of this, diabetes mellitus type 2, although they are most usually young ladies, a degree of dyslipidemia, arterial hypertension, so we may have full-blown metabolic syndrome. What we do not know is if we have a risk for cardiovascular disease in the future. I mean that if a lady of 15 or 25 or 30 has polycystic ovary syndrome, when she reaches menopause some years later, she's 50, 55, if she has increased risk of cardiovascular disease because of this background of insulin resistance. This is a question that up to now remains unanswered. Now, let's return back to our lady that came to us just with the complaint of PCO, of the morphological appearance. The first thing that I have to do is to start with her history taking. So her menarche was at 14 years old without being abnormal. It's rather delayed nowadays. She has only 2 to 3 episodes, menstrual episodes per year. So that brings us much closer to the definition of PCOS. We have now 2 criteria according to Rotterdam. We have the PCOS ultrasound appearance plus the oligomenorrhea. She has a degree of hirsutism since she was 15 years old. She has no acne, it may happen. She takes no other drugs that may actually increase hair, so go to hirsutism. She's not married, she's young, 22, and fertility is not an issue. This is important because we are going to deal with her quite differently if fertility is an issue as compared to the opposite. So no fertility issues at this problem. What do we going to do again after history taking? Of course, clinical examination. So important thing is height and weight in order to have our BMI, and you can see she's an obese lady with a BMI of 31.6. She's quite hirsutism with a Ferriman-Gallwey index of 12. I'm going to discuss about this in a minute. She has no acanthosis nigricans, and she has no classical phenotype or Cushing syndrome or of virilism. Blood pressure is 125/22, so normal, I would say. This is the main thing, the main information that I would like to have from her clinical examination. This is the famous Ferryman-Gallwey score, nothing special. We know this since 1961. So we divide the body in 12 different areas. You can see the upper lip, the chin, the chest, and so on. And we give a grade starting from 0, no hair at all, up to 1, 2, 3, 4, and so on in any one of these 11 areas. So we add all this, and this is the Ferryman-Gallwey score. So it's a way in order to quantify, let's say, the hirsutism. This is acanthosis nigricans. You can see this velvet appearance of the skin. This is an army pit, and this is the neck, and this is an effect of the insulin on the skin. Insulin has to be considered as a growing factor, so in ladies with severe insulin resistance, we may have this finding of acanthosis nigricans. And of course, very important, you have to undress a lady and to see pictures like this in order to exclude them. So this is the classical appearance of Cushing syndrome, a fat lady with rather thin limbs, upper and lower limbs, or on the other hand, to see a very muscular lady with recessing with hairline baldness, with small breasts, with enlargement of clitoral tissue. So these are completely extreme pictures. In the first case, in the last, I would suspect of a benign tumor of the adrenals that produces cortisol, that is the Cushing syndrome. On the other hand, I would think about a malignant lesion of the adrenal that produces testosterone, and this is, of course, the very rare but very dangerous adrenal carcinoma. So these are cases that they have to exclude. And let's proceed with this. Remember that in Rotterdam we have a fourth criterion, that is exclusion of other causes. So we have to exclude androgen-secreted tumors, and these are tumors by the adrenal or the ovary, and other things such as congenital adrenal hyperplasia or Cushing syndrome. I would suspect, these are rare of course, but they are dangerous, I would suspect an androgen-secreted tumors. In the case I have not amenorrhea, but rather irregular bleeding. I have very high total testosterone, usual testosterone in ladies with polycystic ovaries in the upper limit of a female, something like 80 to 100 nanogram per dl. But I see a very high total testosterone, more than 200, then I would start to suspect a tumor. And DEAS, if we have very high concentration of DEAS, this is an indication of adrenal origin of the excess androgen production. Ovarian tumors, we have an ally there, and this is the ovarian ultrasound that then identifies suspicious mass. You can measure endometrial thickness, suggesting hyperplasia, and of course we can confirm PCO morphology. This is an ovarian ultrasound with a mass on the ovary, so an ovarian mass. This is not PCOS. It has increased vasculature. This is, we already discussed it, a thick endometrium. This is in concordance with PCOS, and this is a very thin endometrium. I would not suspect to see this picture in a woman with PCOS and amenorrhea. Adrenal tumors, I can identify them by computed tomography usually, or MRI, and this is a case of this. You can see here an adrenal tumor. Congenital adrenal hyperplasia, this is a disease that I'm going to diagnose it through measurement of the 17-hydroxyprogesterone. You may remember the biosynthesis of corticosteroids from cholesterol. I'm going to have the three main groups of corticosteroids, and this is the aldosterone, cortisol, and the sex steroids. What is happening in the classic form of congenital adrenal hyperplasia is that I have a stop at this level, at the level of 21 hydroxylase. So what is before this stop, like 17 hydroxyprogesterone, is going to get up to be increased, and what is below this is going to be lower. Of course, the system will try to increase the cortisol in an attempt to have normal level of cortisol, but what we're going to have is to produce more testosterone. As you can see, the road is open from cholesterol up to testosterone. So in congenital adrenal hyperplasia, we may have a clinical picture which more or less exactly the same as PCOS. The main difference is going to be that 17-hydroxyprogesterone is not going to be increased in a case of PCOS. So this is what we expect usually. If we give more ACTH in order to increase biosynthesis of steroids, the final steroid cortisol will go up, but this is not true with 17-hydroxyprogesterone. If we have a block there, so a problem in 21 hydroxylase, then 17-hydroxyprogesterone is going to be increased, and this more or less puts the diagnosis of congenital adrenal hyperplasia. If I suspect an overproduction of a hormone, that is Cushing syndrome, I'm going to apply a suppression dynamic test. So I'm going to give the day before 1 milligram of dexamethasone. So what I do expect is next day the morning cortisol to be quite low. So overnight suppression of endogenous production of corticosteroids. If production of cortisol remains high, then I have the first indication of Cushing syndrome. So this is the job of the endocrinology, to exclude cases like this: humors that produces androgen, Cushing syndrome, or congenital adrenal hyperplasia, and usually is going to do this by the application of dynamic tests. Now let's continue with our case and see a little bit of laboratory evaluation of this lady. LH is rather high, FSH is normal, so you can see that the rate of LH to FSH is high. Total testosterone is increased, so a degree of androgen excess, but at about the level I would expect for a lady with PCOS. It's not very much increased, more than 200, as we'll discuss. TEAS is normal, 17-hydroxyprogesterone is normal, so I exclude congenital adrenal hyperplasia. Thyroid axis looks normal with a normal TSH. Prolactin is slightly up, 25 is the upper normal for the majority of the laboratories for a lady. I would expect this, as we have discussed. And glucose is rather high for a young lady. She has not diabetes mellitus, but she has a form of prodiabetes. Glucose is more than 100. And as I would expect, I have the PCO morphology on the ovary plus a rather thick endometrium. Now, that concludes the diagnosis, and I'd like to discuss a little about the treatment, how we are going to deal with this lady. Well, the way we approach it is like this. We may have ladies with different types of problem with PCOS. The only problem may be the PCO morphology, and that's it. And we all agree that this is not syndrome, it's just a morphology. It may be a variation of the normal. On the other hand, women may have menstrual disturbances, may have androgen excess, may have metabolic disturbances, or infertility may be their main problems. So according to the problem, I'm going to have different therapeutic approaches. So let's say that the problem is the morphology only, the problem is menstrual disturbances, the problem is hirsutism, the problem is metabolic syndrome, components of the metabolic syndrome, or the problem is infertility. In case I have polycystic morphology only and no other problem, no androgen excess, no menstrual irregularities, I'm going just to confront, to cancel the patient. Of course, it's always good to do some lifestyle modification, to stop smoking and to lose some weight and start exercise. if the main problem is the menstrual disturbances, we have a lady with amenorrhea, let's say, but few skin problems, then once again, the first approach would be lifestyle modification. I'm going to lose fat, so my testosterone will be go a little down, and this will improve my clinical picture. Then I may give metformin, although it's not very effective in restoring menses. What is very effective is giving progesterone. Remember that women with PCOS, she is very well estrogenized. We have no problem with estrogen. The problem is that we have no ovulation and no production of progesterone. So if we give progesterone for, let's say, for 5 to 10 days, 7 to 10 days, so we simulate a luteal cycle, the luteal phase of the cycle, we are going to have menstrual period in almost 100% of the cases. Of course, if we give a combined oral contraceptive, we're going to have periods as well, but this is not necessary for a lady with PCOS. Progesterone is enough. If the problem is hirsutism, I'm going to start with lifestyle modification. I'm going to, once again, my testosterone will go a little bit down, so this will improve my hair pattern as well. Of course, I may apply topical therapies. I may give a combined oral contraceptive, and of course one that it has anti-androgenic properties. The progestogen component has anti-androgenic properties in order to decrease the production of testosterone. And of course, I can give additionally potent anti-androgens such as cyproterone acetate, finasteride, flutamide, and so on. If my main problem is the metabolic syndrome, once again, lifestyle modification for obesity, for dyslipidemia, for arterial hypertension. I may give metformin. I may apply specific therapies. I mean, anti-lipid medication or antihypertensive medication. And if the problem is infertility, I'm going to start for the fourth, fifth time with lifestyle modification. It's in the back of everything. And then I may continue with clomiphene citrate or other specific treatment. I'd like just in 5 minutes to present these cases. So lifestyle modification, you can see that it's very important for almost every type of problem in a woman with PCOS. And I don't know if you can read it, but we have some evidence here that if you lose something like 5% of your body weight, you may even double the number of your menstrual periods per year. And that means a doubling in ovulation as well. So it's important for very many things. Metformin, you may see an improvement with metformin in ladies with PCOS. Insulin resistance goes down and testosterone goes a little bit down. On the other hand, of course, is the first line of treatment in a lady with diabetes. Can be used even in cases of pre-diabetes or increased insulin resistance. This is the way metformin acts actually through reduction of the liver glucose output. Usually it's a drug that is easy to use. Now concerning progesterone, once again, it's going to solve in almost 100% of the cases the problem of menstrual periods, going to restore menstrual periods. So if you give the natural product progesterone or medroxyprogesterone, once again for 7 to 10 days, menstrual periods will follow 2 to 3 days later. Combined oral contraceptive, we use it usually here in case of hirsutism. So if lifestyle modification is not enough, if topical therapy is not enough, then we have to give a combined oral contraceptive with anti-androgenic properties, such as the combination of a phenylestradiol with cyproterone acetate, or this one that's a combination of phenylestradiol once again with drosperinone. So these progestogens, drosperinone and cyproterone acetate, they have anti-androgenic effects, so they are effective in cases of PCOS. Of course, you can use, the ladies are very familiar with this, many different ways of topical therapies, shaving, chemical peeling, wax hair removal, laser therapy, photolysis, electrolysis, and so on, in order to have an acceptable cosmetic result. Of course, we have to deal with cost. Sometimes they are painful, adverse effects, and the efficacy of this. Of course, if we want, this is rarely happens in PCOS. Usually the hair treatment is mild, but of course we can give even more potent anti-androgen than the combined oral contraceptive. So we can give spironolactone, or we can give cyproterone acetate, or we can give finasteride or flutamide, that they act through different modes of action. For example, finasteride inhibits 5-A reductase, and flutamide binds to the androgen receptor. So we always have the means to deal with the hirsutism, although this is usually not the case. Usually things are quite well with giving a combined contraceptive. So we stop up to here. Sometimes we add some additional cyproterone acetate. Now, concerning the fifth type of problem, the infertility, clomiphene citrate has been indicated as a first-line treatment in order to restore ovulation, and this is the way it acts. In an estrogenized lady, that is, as are the ladies with PCOS, clomiphene citrate blocks the estrogen receptor at the hypothalamic and pituitary level. So the body thinks that there is no estrogen around. Of course, estradiol is there, so it produces more FSH. So this may restore ovulation, and this is the way that clomiphene citrate acts in order to improve fertility in these ladies. Of course, if this is not enough, we can go up to ovulation induction, ovarian drilling, or assisted reproduction techniques like IVF. Today is very uncommon a lady with PCOS not to solve her problem, actually. We may go up to here, up to assisted reproduction, but in the great majority of the cases, the couple will going to have a baby. If you want to read more about how to treat specifically infertility, that was there in the second consensus of ESTR and ASRM that took place in my city, Thessaloniki, something like 10 years ago. So the consensus of how to treat infertility in women with polycystic ovary syndrome. I have to say, closing this second part of the presentation, that the physical history of PCOS is something like this. I mean, it starts from the puberty, and they are periods of remission and periods of increased problems. So what we have to do with treatment is to apply treatment at the beginning of a bad period, when problem starts to emerge, actually, in order to avoid to go there. I mean, to avoid amenorrhea, to avoid severe skin problems. So every time that we see that there is a relapse in PCOS, we have to act quite early in order to avoid this phase. And of course, PCOS remain a disease of the second decade, of the third decade. Ladies of 20 or 30, it's not a problem anymore as the ovary gets older and has fewer and fewer follicles there. Most probably after a pregnancy, the problem disappears altogether. My message is up to now is that we always must have a distinction between PCO and PCOS. So it's not enough to have just the morphological appearance. We must have the syndrome as we defined it. We need a complete history and clinical evaluation, the way we approach it with specific history question and specific items of clinical evaluation. We have to perform selected laboratory and imaging investigation. We went through this. To focus on specific clinical phenotype, we discussed 4 or 5 phenotypes, the metabolic syndrome, infertility, mainly androgen excess, mainly menstrual disturbances. And of course, we have to scale our treatment approach according to the severity of the problem, according to the diagram we discussed. Now, I'd like to finish the last 5 or 8 minutes with a little bit of the background, a little bit of the pathogenesis of the syndrome. And it's quite interesting to see that we had different eras of this syndrome. The first era was the era of observation. We said that in the syndrome, of course, the ovaries were involved, and the upper level, the pituitary was involved, adrenals were involved, the pancreas with production of insulin was involved, the peripheral muscle was involved, even the fat tissue was involved, and even the liver was involved. And what were the main laboratory findings from this organ? Well, from the ovary it was excess production of testosterone. This is the cardinal feature, the endogenous excess production of testosterone, and another feature, of course, is loss of ovulation. From the pituitary, we discussed it, we have increased LH and FSH. From adrenals, we have sometimes, not all the times, increased production of steroids. From the pancreas, we have increased production of insulin, but because we have insulin resistance, we do not have hypoglycemia, we have hyperglycemia because there is insulin resistance. And from the liver, we have decreased production of SHBG. So that was the era of observation that polycystic ovaries, it's not just the ovaries, but other organs are involved. The second era was the era of theories. For example, the theory of the ovary. The main problem is the ovary that produces testosterone in excess. And according to this, this is why there is no reduction of LH, so that is why we have increased production of LH. But the main problem is the ovary. We had the theory of the pituitary, that the main problem is locating in the pituitary, actually, that produces high amounts of LH, and as a consequence, we have high production of testosterone by the ovaries. We have the theory of the adrenals, that the androgen excess were of adrenal origin, like DEAS and delta-4 androstenedione. We have the theory of the liver, that because of the decrease in SHBG, we have increased free testosterone that's around in the blood, or the same is true for the ovarian production. But the main theory appears to be the latest one, and it is the theory of the insulin that says that insulin acts to the ovary, and actually insulin is a drive for the ovary to produce testosterone. We are going to discuss for this. Insulin acts to the pituitary and is the drive to produce more LH than FSH. Insulin acts to the liver and reduces the production of SHBG, but insulin, in a way, does not act to the peripheral tissues, that is the fat tissue and the muscle, so does not allow for glucose to enter this tissue. As you can see here, that this is a control ovary, and this is an ovary that I treat with HCG, so I'm giving gonadotrophin, so actually I'm overstimulating this ovary, and I have an appearance like PCOS. If I give insulin, I have exactly the same pattern. So insulin can make the ovary to have this pattern and even produce testosterone. And if I have a combination, look at the result, combination of ovarian stimulation by HCG plus insulin. So it seems that insulin production is central to the problem, to PCOS. On the other hand, there is a peripheral insulin insensitivity of some tissues. One may say that we may have different types of insulin, but in human body we have only one insulin. One may say that we have insulin mutation, but no such mutation were found. One may have that we have in different organs different types of receptors, but there is only one type of insulin receptor. So it seems that the problem is intracellular. Something is happening after the after insulin binds to its receptor. And now we know, in the era of molecular biology, we know what's happening. Up to now, the peripheral tissues were like a black box. We knew that when insulin binds to its receptor here, a door opens actually through glucose transport and glucose enters the cell. Today, we know that a lot of intracellular things take place. For example, one is the exact way by which insulin allows to glucose to enter the cell. This is through tyrosine kinase, through IRS1, through PI3-1, and the production of the glucoprotein. But on the other hand, insulin has other actions. It has anabolic actions by acting directly to DNA synthesis or unlocking gene. And as we've discussed, insulin is capable of stimulating steroidogenesis. So imagine if we have a problem here. So if in PCOS we have a problem at this road, something like a mutation on another intracellular problem, then all the other roads would be open. The body will produce, the pancreas will produce more and more insulin, and this is happening in PCOS, in order to overcome this problem. Of course, there would be a problem of glucose to enter the cell because of the problem in this road, so hyperglycemia. On the other hand, the increased production of insulin would result in increased production of testosterone, which is the case in PCOS. That's why insulin, the insulin theory actually explains a lot in this case. Of course, genetics are involved in PCOS, and as you can see here, in twin studies, the monozygotic concordance is quite high in women with PCOS, so there must be a genetic component there as well, having to do with different types of genes, and these are some of the genes related to PCOS. It has to do with very many different things. What do we believe today is the famous two-hit theory. I mean, I must have a congenital predisposing hit, a first hit, and then to have a second one, a postnatal provocative hit, in order to have the full-blown syndrome. Finally, another component in the pathogenesis of PCOS is the oxidative stress. We know that ladies with PCOS have a degree of oxidative stress, free radicals, ions, molecules, things like this. And this is a try of our group actually trying to see markers of stress and of oxidative stress and cardiovascular degree in women PCOS. And you can see that almost every index that you would like to investigate is going to be increased in women with PCOS, like C-reactive protein, like homocysteine, like ADMA. Even if you go in specific markers of oxidative and antioxidative stress, you are going to see that all the promoters of the oxidative stress are increased in PCOS, and all the antioxidants are decreased in this syndrome. So it has to do with oxidative stress as well. It's not only the vicious circle of obesity, that means androgen excess, that means more obesity, insulin resistance, and so on. It has to do at an inner cycle with oxidative stress as well. So that was it. Thank you very much for your kind attention.
Thank you very much, Dimitrios. That was very interesting, and I think everybody might think the same. So now we have a few polls that yeah, we need them to be answered. I will launch now the first one. Just a second. Okay, so I just launched the first one. and you will have a few seconds to answer. So yes, people are starting to answer. It's still moving. Let's wait a couple of seconds more. Still moving. Okay. Yeah, let's see the result. Okay, Dimitrios, what do you think about the results?
Ask of this. So I would say both. Of course, as you correctly said, the majority of you, oligoovulation alone is not enough. Hyperandrogenemia is not enough. So you must have both in order to have the definition of PCOS according to the Rotterdam criteria. Of course, some of you answer none because said that none of this is absolutely necessary. I may have a combination of either oligo-ovulation or anovulation or hyperandrogenemia with the PCOS morphology. So I would say as correct answers the both and the none. But the thing is that according to the Rotterdam criteria, I must have 2 out of 3. Oligo-ovulation, hyperandrogenemia, and PCO. 2 out of 3.
Okay, so let's go to the second one. Progesterone is expected to be effective in restoring which of the following PCOS-related issues? Oligoamenorrhea, hirsutism, hyperglycemia, or oligoanovulation? We're gonna give a few seconds also. While you respond to this, let me remember again, if you have any questions that came up during the presentation today, you can type them into the question section. I will be reading them to Dimitrios just after the polls. You can write them in the control panel. Okay, so looks like people have already answered. So here are the results, Dimitrios.
Yes, so the correct answer is oligoamenorrhea. Once again, we said that these ladies are estrogenized. So if you give the second component, if you give progesterone, you are going to restore menstruation. Progesterone has nothing to do with hirsutism. It's not going actually to reduce testosterone. It's not going to improve hyperglycemia, and it's not going to restore ovulation. Ovulation did not took place actually. The only thing we do is to drop the endometrium, that is menses actually, but of course we do not restore ovulation with progesterone. In order to restore ovulation and have fertility, we have to give clomiphene or go to the other methods of ART actually, of assisted reproduction techniques. So correct answer is A.
Like the majority said. So let's go to the third and last one. It's a characteristic laboratory finding in women with PCOS is increased FSH and LH ratio, low serum estradiol concentrations, mild hyperprolactinemia, increased 17-OH progesterone concentrations. Okay, so people are already answering. Let's give like 5-10 seconds. It's still moving. Okay, we're going to finish this already. Oh, this is a little bit more fight.
So some of them may confuse. What we may have in PCOS is increased LH to FSH ratio, not FSH to LH. So if something is increased, is LH. So of course this is not true. FSH is not increased in PCOS. As you correctly said, we do not have low serum estradiol concentration. They are normal or increased. We have mild hyperprolactinemia, and we do not have increased 17-hydroxyprogesterone in case of PCOS. This is true in case of congenital adrenal hyperplasia. So if we find increased levels of 17-hydroxyprogesterone, we will suspect congenital adrenal hyperplasia, not PCOS. So the correct answer is the C, mild hyperprolactinemia.
Great. So I guess yeah, there was a little confusion that everybody now has clarified. So this was the poll part, and now we're going to answer the question. We have just two of them. You are still on time to write some of them if you still have some doubts. So let's go with the first one. It's, can high dose micronized progesterone help with endometrial hyperplasia and DUB? Dimitrios, I don't know if I was clear enough.
Yes, you were clear enough. The answer is, of course, yes. If a lady has already 3 to 4 menstrual episodes per year, I would not be afraid of cases of endometrial hyperplasia or atypias or cancer. 3 or 4 falls of the endometrium, 3 or 4 menstrual periods per year are usually enough in order to avoid this risk. Any case, if you give progesterone, micronized progesterone, of any type of progesterone actually, as we said, in almost 100% of the cases, will induce the menstrual period, and of course you will avoid, almost, the risk of hyperplasia goes almost to zero. And that's what you have to do. You have to be ensured that the lady has at least 3 or 4 menstrual episodes per year. Otherwise, you can give progesterone. Actually, you can give progesterone in 2 ways. One is every month, so from the 1st up to the 7th day of the month, and you would expect the lady to have periods at about 10th of impact, so 3 days after withdrawal of progesterone. On the other hand, something we do in clinical practice is to give progesterone every 45 days. So especially in cases not of amenorrhea, but of oligomenorrhea, we do wait a little to see if there is an endogenous period, if the lady is going to have period by herself. So we wait in 30, 35, 40, 45 days. And if not, then we give progesterone for 7 days and we induce a menstrual period. In this way, we have at least 1 period every 2 months, and we are away from risk of endometrial hyperplasia.
Okay, let's go to the second question is, do you need laboratory proof of insulin resistance to use metformin, or can you use it empirically?
Yes, that's true. Actually, we do not, and there is no organization that actually wants to measure insulin or the ratio of glucose to insulin, or all the other indices of insulin resistance we have, such as HOMA or QICI or any other thing. We usually do it empirically. So if we see a lady with increased triglycerides, which is a very good index of insulin resistance, or of course a fat lady with increased waist circumference, and of course a lady that has prodiabetes or even diabetes type 2, we are going to give metformin. I'm not going to give metformin in all ladies with PCOS, where I suspect insulin resistance, but once again, it's not necessary a necessity to measure insulin. I would give metformin for a certain period of time. In the meanwhile, my main approach would be to persuade the lady to increase physical exercise and lose weight.
Okay, So as we see, the questions are starting to boost, and we are having a few more. So next one is great presentation, Dimitrios. I agree with that. I would like to ask you if it's possible for a woman to have clinical symptoms or androgen excess, but with normal laboratory androgen levels. Also, if the rest of the Rotterdam criteria are normal, this means that it is an idiopathic cause.
Yeah. Concerning the first, yes, this is true. I mean, it's not just the amount of androgen, let's say testosterone, that's circulating in the blood. The action of this testosterone may be different. So we see women with rather increased degree of biochemical, let's say, androgen excess, so high levels of testosterone, but they do not have excessive hirsutism. And the opposite, some women have excessive hair at specific patterns without having so increased testosterone. Most probably, obviously, it has to do with the action of testosterone at a topical level, at the hair follicle, let's say. So there are some ladies that are very sensitive to this, and even with small increases in testosterone, they have this. Even with the same degree of testosterone, you may have different appearance. I mean, with the same degree of androgen excess, other ladies may have hirsutism, other ladies may have seborrhea, other ladies may have acne. So it has to do with the topical sensitivity of the tissues actually to androgen. So yes, it may happen. You have to measure both testosterone and see the clinical picture. Concerning the second one, yes, as far as the Rotterdam criteria are not fulfilled, then in the very vast majority of the cases, we have a case of idiopathic hirsutism. Just to have it roughly in the back of your mind, if you have a lady with hirsutism, the chances is something like 45% to have PCOS, polycystic ovary syndrome, something like 45% to have idiopathic hirsutism, so hirsutism, but no increased androgen, no menstrual disturbances, no infertility, so this is idiopathic, and there is something which hopefully is less than 10% that has to do with the other causes, that is congenital adrenal hyperplasia or tumors.
Okay. Next one is asking how long to continue spironolactone if used to address hyperandrogenism.
Yeah, actually in Europe we do not use so much spironolactone. We would go to combined oral contraceptive or cyproteron. Actually, we combined always with a contraceptive. But if I use it, actually I had this in the back of my mind. The mean life of a hair follicle in the human body, so in the scalp or in the skin, is something like 8 to 9 months. So my intention would be to give spironolactone for this period of time, so more than 6 months and less than a year, something like this, in order to have a new generation of hair produced while the amount of testosterone was less actually. So that would be my approach to this, to give spironolactone for 6, 9, 12 months, things like this. And remember that diagram I showed, that there are in a lifetime of women with PCOS, there are good times and bad times. I would try to start spironolactone or another antiandrogen at the beginning of the bad time in order to go away for the severe clinical picture. In the meanwhile, there may be periods, even years, that the woman has much better menstrual pattern and much better hair pattern. Every time that we enter a bad period, actually, I would try to see what's happening in the environment. Did she put on weight? Things like this. And then I would start my pharmaceutical approach.
Okay, so we have a couple more. Any special issues in menopausal patient who has been diagnosed PCOS during generative phase of life?
That's a hot topic. If you take a cohort of women with PCOS, you are going to see that they have all the bad things in the world. I mean, they may have dyslipidemia, a degree of it. They may have hypertension. They may have, as we discussed, a risk of oxidative stress, insulin resistant, of course, we said it. So you would expect when these women grew older and reach menopause, let's say, to have an increased prevalence of cardiovascular disease. On the other hand, prospective cohorts show that things are not like this. Most probably, something is protecting these women with all these risk factors for cardiovascular disease, eventually not to develop cardiovascular disease. And this is a really hot topic now in reproductive endocrinology. Let's say the long-term consequences of PCOS. After some years, PCOS is not a problem anymore. A woman that enters menopause, she has no problem with her periods anyway, she's postmenopausal. She has no problem with fertility, she's quite old now. She has no problem either. So PCOS does not exist anymore. So what's the future of this woman? Is she on increased cardiovascular disease because of her previous PCOS, of the history of PCOS? The answer is, it seems no, and we try to find the mechanism behind it.
Okay, so last two questions. Can metformin be of any help in cases of androgen excess, Dimitrios?
There are some papers saying that you would expect to lower testosterone by something like 10% if you give metformin. It improves insulin resistance, and that means lower insulin by definition. And you remember, I showed you the slide, that increased insulin may result in increased steroidogenesis, increased production of testosterone. So in theory, testosterone may reduce, metformin may reduce testosterone, but it does make so in a small amount, less than 10%. So you do not see a real improvement, especially in skin problems. So if the problem in my lady is usually a skin problem, hirsutism, acne, seborrhea, things like this, I would go directly for an anti-androgen, spironolactone, cyproterone, flutamide, finasteride, things like this, and not metformin. It's not very effective.
Okay, should we need to measure free testosterone?
Not at all. In order to measure free testosterone, you have to do it the right way, and the right way is equilibrium dialysis. There are very few laboratories in this planet that they are performing equilibrium dialysis. So although it's a general rule in endocrinology that the active form of a hormone is the free one, this is an exception. So do not measure free testosterone. Many laboratories measure free testosterone, but with other less reliable techniques. So measure total testosterone, and there are formulas, we can find them very easily in the web, that you can calculate free testosterone by entering total testosterone and SHBG. So please do this, and do not measure and do not trust measure of free testosterone.
Okay, we have a last question, Dimitrios, that entered just a couple of minutes ago. Does letrozole has any edge over clomiphene citrate?
Yeah, this is another thing. When we had the Thessaloniki consensus, the answer was no. The first line was actually clomiphene citrate. There was some concerns about some congenital abnormalities, congenital malformations in babies conceived while the women with PCOS was on letrozole. it thinks that things are not like this, and the aromatase inhibitor, like letrozole, actually have a place very near to clomiphene citrate in the induction of ovulation in ladies with PCOS. So you may use it as an alternative to clomiphene.
Okay, so this is it for the questions. Those were very interesting ones. Yeah, so all right, thank you so much. This concludes the presentation and the webinar of today. So thank you so much for your wonderful presentation, Professor Dimitrios Goulis, and thank you for all the attendees for being here today and for the question and for answering the poll. So just a quick reminder, as I said previously, you will receive a brief survey that will pop up when I end the webinar, and yeah, we will really appreciate you to respond. It's going to help us a lot for the next webinar. So thank you everyone, and have a great rest of the day. Thank you, Dimitrios. Thank you very much.
Thank you. Bye-bye.